everyone. My name is Michelle Wilson. I'm a speech pathologist. I work at Johns Hopkins. I'm at the Bethesda office right around the corner here, actually. My specialty, I will admit, is not in these neuro disorders. I, in fact, see more head and neck cancer population. However, I do hope I do have something to contribute to you and for you, and that you take away some good information today in regards to your swallowing. So with the next slide is that I have no disclosures. I'm not paid by anybody other than Johns Hopkins to say this. So why are you seeing a speech pathologist for swallowing? I have a lot of folks that tell me, why do I need to see a speech therapist? I talk fine. Well, I mean, yeah, you might, but it's part of our scope of practice here to also look at your physiology of swallowing, because a lot of our training is done with anatomy and physiology of the neck and the mouth and the head. It made sense for swallowing to be part of that scope of practice for us. So we look at the physiology of swallowing. We look at the safety. How safe is it? Is your diet? How safe is it for you to swallow? We look at, any not diet recommendations of don't eat 2 donuts, but we look at things like, is it safe for you to be drinking thin liquids? Is it safe for you to be having that steak twice a day? Or what strategies can you use to help you swallow those certain consistencies? We also look at anatomical variances in your swallowing as well. Say someone has had a part of their tongue, they've had to have part of their tongue removed. How is that going to impact your swallowing as well? In addition to therapeutic recommendations too. So when you have a swallowing evaluation, it shouldn't stop at the evaluation. You should be getting recommendations and further treatment to work on your swallowing problems. So dysphagia, what is dysphagia? Loosely defined, it's difficulty swallowing or a swallowing disorder. We all have problems swallowing sometimes, every once in a while. You've heard people say, oh no, it just went down the wrong pipe. And that happened to me the other day. Does it mean I have dysphagia? No. But it's when you have a chronic problem. It's when you feel like, okay, every breakfast meal, I'm coughing on my orange juice every day. It's when it becomes chronic and long-standing is when we really want to take a look at it, because that's not normal for you to be coughing and choking on every single meal that you eat. It's not normal for you to be avoiding certain foods because they're hard to get down. So a little bit about the anatomy of the swallowing. What I look at when I see my patients is first is the tongue. That's the the big muscle in the back there. Then at the roof of the mouth, we look at that. At the back of the mouth, there's that velum, so the velopharyngeal port that connects your nose to your mouth. Down into the throat, we have the epiglottis. That's this piece of tissue or piece of cartilage that pops up from the larynx, and then when we swallow, it flips over and helps cover our airway and helps protect us. Then down below that, we have the front pipe. That's your windpipe or your larynx and your trachea. And then right behind that, we have the esophagus. So when we breathe and when we eat, they actually go along a common pathway until they reach that upper esophageal sphincter, that level of the cricopharyngeus. So that's where we can run into a lot of problems with swallowing. And next slide. All right, so this is just another view of, this is actually from a modified barium swallow study. That's when you swallow in front of an x-ray. And so when I do those studies, that's kind of the view that I get. I'm looking at your anatomy in that picture. And another view of our throat is, so this is a throat. This is nothing else. But this is the back of a throat. That's your larynx there in the middle. That V, those two lighter pink tissues that in the V, that's those are vocal folds. Above that, you see towards the bottom of the picture, there's that flap of tissue that kind of looks like it curves up and downwards. That's your epiglottis. The top of the picture is the back wall of your throat. And then what we don't see here is right at the bottom of that back wall, just behind the vocal folds there, that's the entrance to your esophagus. So that's another view of the inside of your throat as well. So Everybody take a moment. For those of you who can swallow, just take a quick swallow. Either some water just take a quick swallow, either some water or what you have in your mouth. Just take a quick swallow. Took about a second or two. A lot happens in that time. We break down the swallowing when you evaluate into 3 different phases. We have the oral phase, pharyngeal, and esophageal. So we're going to walk through what happens in each of those phases. So the oral phase is really when food passes through the mouth. What can happen there is what we look at is what the tongue is doing with the food, or the bolus. Bolus is that term that we use for that sip of liquid that you take, that bite of food that you take. So what is the tongue doing? Can it cup that liquid there? Can it hold that liquid in your mouth? When you're chewing and you're masticating, does it move it around, or is it really kind of just mashing the food wherever? Is it able to organize the food in your mouth? So when you're chewing, are you able to collect it in order to get it ready to swallow? And when you do initiate that swallow, where does that food move? Hopefully what we see is an anterior to posterior, front to back movement of swallowing. And how does it achieve that? Is the tongue pressing up at the roof of the mouth, or is it just kind of throwing things back there? So what's going on with that? Another thing that we're looking at is that velum, that soft palate where your uvula hangs off of at the back of your throat, is that lifting up? Because what that does is it cuts off the mouth from the nose, and that prevents food from coming out of your nose. So if a patient tells me, I get food that comes out of my nose pretty much all the time, or I get a lot of times I'll drink some water or something and it comes out my nose, that's something I'm going to be paying attention to in your evaluation, is what's going on with that port there? Why are we getting food coming out of the nose? And so once that food passes from the mouth down into the throat, that initiates then the pharyngeal phase. So this is a picture kind of loosely showing you what happens in that oral phase. So we see the tongue with the blue bolus there. That tongue is cupping the liquid or whatever that's supposed to represent. And we see that tongue pushing up against the roof of the mouth, and that pushes that food towards the back of your throat and down to your throat. Okay. Next we have the pharyngeal phase, and that's when food passes through your throat. What happens there, what I'm looking for is what is that tongue doing? It's that tongue pushing to the back of the throat, because what that does is help create this driving force to push the food down towards your esophagus. What is the larynx doing? The larynx has a big role in this part of the swallowing. First and foremost is to protect your airway, making sure that food is going down the right way. We want it to go down your esophagus and not down into your airway. So I'm going to watch that larynx. Is that epiglottis, that piece of cartilage, is it flipping over all the way? Or does it kind of not get all the way over? Is that larynx able to lift up in the throat? That larynx, in order to get this flipping function of the epiglottis, needs to lift up. So is there trouble with that larynx getting up in the throat? What are in doing so with that laryngeal lift that we see, that helps the true vocal folds, the false vocal, we have several folds in our larynx. So the true vocal folds, the false vocal folds, and the aryepiglottic folds, those need to close off, and that's another layer of protection against your airway. So when that larynx doesn't quite lift, okay, what then can we maybe anticipate in that regards to your swallowing? And the pharyngeal constrictor muscles, we have these muscles along the back of our throat that move from top to bottom and help push that food down into your esophagus. So again, in that 1 to 2 seconds it took you to swallow, there's a lot going on. There's a lot that I'm looking for when I see my patients swallowing. So the next picture is just a visual of what we look for, what typically happens when you swallow. So you can see that back wall of the throat pushing in towards the tongue, making contact, and that pushes that food through. We have the epiglottis that's flipped over, covering our airways, and boom, food is going down to where it needs to go, past the upper esophageal sphincter. All right, and then the third phase is the esophageal phase. This is when the bolus, or the food, passes through that upper esophageal sphincter, the cricopharyngeus, and it goes through the esophagus down to the lower esophageal sphincter and into your stomach. It's pushed down by a process called peristalsis, so it's almost like the muscles move in this wave action from top to bottom, pushing that food down. It's pretty cool to see on x-ray when I do swallow studies. It's almost like a little corkscrew of food going down the esophagus. So in that respect, when I'm doing that kind of swallow study, when I can assess the upper esophageal sphincter, I'm just looking at that. Can that open? Is there a bar there? Is there some sort of constriction in that upper throat that's preventing food from going down? And then gastroenterology, they get a little territorial about this. They want to see the rest of it. So if there's anything I notice that's in the middle or lower esophagus, I'm going to say, let's defer this to GI. That's going to be their issue there. So I'm mainly looking at the top part, but that doesn't mean that I can't make referrals to gastroenterology. All right, so now that we know what we're looking for in terms of swallowing, what do I look for when you show up at my office as part of my swallowing evaluation? So first, before you come, hopefully I have access to some sort of patient history. What I want to know is, what is your diagnosis? Are there any concurrent diagnoses? And what role does that play in your swallowing? So kind of what is this going to do to your swallowing, these certain diagnoses? Any prior medical treatment? Have you had any chemo or radiation? Have you had any major surgeries? Have you had any dilations in the esophagus? Those are things too that I'll want to get a sense of before looking at you. Also, is there any imaging available? Do I have access to any MRIs or CT scans? Especially for my neurological patients, folks who have had a stroke, where was the infarct and what is that also going to do to your swallowing? What also is your respiratory status? That also has a great impact on your swallowing. Are you on oxygen? Do you have a tracheostomy? Are you on some sort of vent? This is especially important for when I see patients in the inpatient or the inpatient rehab setting. What is the respiratory status? Can we do a swallowing evaluation? Is it safe for them to swallow at this point? And then also I want to know if there are any current diet orders. So what has someone said previously about your swallowing? Has someone told you shouldn't drink thin liquid, you have to be drinking nectar thick? Or someone has said you have to eat only purees? What previous orders have you been given in that respect? Also a little bit about the backgrounds. When I talk to you, the patient, or when I talk to my patients, I'm going to ask certain things like, first and foremost, do you find that you're coughing and choking when you eat? That's usually my first question that I have for my patients. And if they answer yes, okay, well, when does it happen? Does it happen with foods and liquids, one or the other? There's certain foods that you notice that it happens with. Because again, coughing and choking with every meal is not normal. That needs to be looked at. Also, different sensations. Is food or liquid? Does it feel like it's getting stuck somewhere? Does it feel like when you swallow a piece of bread, it just takes a lot of effort to go down, but eggs go down just fine? What about weight loss too? Have you been losing weight without trying? Or have you been trying to maintain weight, but you have to have like 3 Ensures a day to maintain that weight? Really, what does that also look like? What is your appetite as well? Is there a component in that respect? What about dry mouth as well? Does your mouth feel dry all the time? That's also going to impact your swallowing. And these are probably little minor things that you may notice about yourself that you don't really think, oh, it's just something I live with. It's something that's fine. But no, these all have an impact on your swallowing as well, and I want to know about that. Certain things too I'd like to know about are, have you noticed any changes in your voice? Again, that larynx is a big function of swallowing, so is there anything that you've noticed about how it works? Is there anything that has changed about your voice? That's something I want to know as well. History of acid reflux, but also more importantly too is, when did all of this start? How has this been progressing? Has this been a sudden onset, or has this been kind of going on for several years and it's just slowly and slowly getting worse? What does that picture look like? Another thing that I'm informally looking at as well is kind of just a general picture of cognition, language, and speech as well. Cognition is, can this patient follow my directions? How's their memory look like? If I have to give any sort of exercises or compensatory strategies, are they going to remember to use it? What sort of support do they have at home? Do they live alone, or do they have someone that can help them out at home? Judgment as well. I mean, is this person going to, what does that picture look like? What kind of, how accepting are they going to be of any recommendations I may need to make as well? All of that really tends to play a role in my evaluation. So that's the initial first part of just getting a picture of this patient that sits in front of me. Who are you? What are you about? Then we move on to the instrumental or the swallowing evaluation part of that. And there are three major kinds of evaluations that can be done. We'll go through those, but the first one is just the clinical bedside evaluation, and then two different kinds of instrumental evaluations. One is the fiber optic endoscopic evaluation of swallowing, and then modified barium swallow study. And again, we'll go through those. And then finally, once all of that is said and done, once we have that evaluation and we kind of know what's going on with your swallowing, what can we do about it? And always ask your speech therapist when you get a swallowing evaluation, okay, what can be done about this? What can I do? Don't just accept that, well, here's what it is. I always try to give my patients something that they can do, because you're here to see me for a problem that you're having and you're looking for some answers, and I want to give you those answers. So I do my utmost to give you something to help improve your life, So ask that of your therapist. Okay. So the clinical bedside swallow, it's pretty much what it is. It's at bedside. So there's no sort of invasive imaging. There's nothing down the nose. You're not standing in front of an x-ray machine where I'm just sitting and watching you swallow different consistencies. And when I'm looking for kind of those overt signs and symptoms of anything that's going wrong. So when you take a swallow of a sip of water, I'm going to ask you, take one sip. Okay, what does that look like? All right, now take a bigger sip. Now take several sips in a row. What goes on with that? Are you coughing and choking when I ask you to take several sips in a row? Is your voice all of a sudden, is there a change in voice quality? Is the sound wet all of a sudden? Is everything not quite clearing from the mouth? Is there anything that's coming out of the front of the mouth when you swallow? Is there anything coming out of the nose? Those are some clinical signs of something that's going wrong with your swallowing, and I want to take a look at that. That's going to drive kind of what sort of instrumental evaluation I may want to do if it's warranted, or if there's any compensatory strategies that we can implement in the meantime to help make swallowing a little easier. Very rarely do I make any changes to diet recommendations based on a clinical swallowing evaluation, because I really don't know what physically is going on the inside. Are things going down the wrong way? That's the main thing that I'm really paying attention to. So if you ever run into a speech pathologist and they look at your swallowing and they kind of do this clinical evaluation, they say, all right, you're going to be drinking honey thick and you're on puree. Well, okay, why? They didn't see if things were truly going down the wrong way. They don't really know without visualizing what's going on. So I think that's so important, is to really get a good objective view of what's going on. So I wouldn't, if I were in that patient's shoes, I would not accept that. I would say, no, I need to have an instrumental evaluation. So it begs the question, is this a screen or is this an evaluation? I approach it more as a screen. This is just something that is going to say, okay, does this warrant further imaging for this? Or are there things that we can do to help, in the short term? Right. So instrumental exams. So we have the FEES and the modified barium swallow study. The FEES are the fiber optic evaluation. That's just done by an SLP, and that's actually primarily what I do in my own practice. I do FEES every week. That is done with the scope through the nose, and I watch you have a snack while my camera's sitting out in the back of your throat. The modified barium swallow study that's jointly conducted with an SLP and a radiologist is different from a barium swallow study. Barium swallow study is typically ordered by gastroenterology, and the SLP is not present. So I have some patients who tell me, oh yeah, I had a swallow study done. And I said, oh, well, who was what did the speech therapist say? Well, there was no speech therapist there. That was a barium swallow study. They're looking at from the upper esophageal sphincter down to your stomach. They don't look at your swallowing. They may make some observations. They may say like, oh, patient aspirated. Okay, well, what did you try with that? There was no treatment administered with that. So that is different from the barium swallow study. The modified barium is where you're having some foods and you have that with a speech therapist there, and you're going to try some strategies if anything does go wrong. Both are excellent for quantifying that risk of aspiration, and they're going to identify any sort of cause of dysphagia for you. Really, the objective is to see which swallowing strategies and which diets are safe for you. All right, so a little bit about that phase. To give you a picture of, that's where I put my scope, the scope through the nose. I follow along the floor of your mouth, floor of your nose, and I go just down the back of the throat. It's an awake procedure, so a lot of patients come and they ask, oh, I fasted before, so I didn't have anything to eat. You don't need to do that. It's just, you can have a snack beforehand, but I'm just gonna, it's an awake procedure. You can walk out of my office afterwards and drive yourself home. It's an outpatient procedure. And it's a topical anesthetic that I just apply into the nose to make it a little easier for my scope to pass through and make it more comfortable for you. What I do is I have you eat and drink some liquids and solids while I have that camera down the back. And usually what I'll do is I put some food dye into drinks and some of the foods so that I can see it in contrast to whatever secretions that you have in the back throat. It helps me also better visualize if there are any incidences of aspiration. The benefits of that FEES exam is that it's very sensitive to detecting that aspiration. It really provides I like that FEES because it provides a good view of the tissue health. It helps me see are there any masses back there that we need to be concerned about. How is the larynx moving? Can the vocal folds come together completely? How are things looking down there? Is there any inflammation in the throat that's causing a problem with swallowing? But some of the drawbacks to that are that it doesn't show me what's going on inside of the mouth. Again, what is that tongue doing? How are you moving food around and through the mouth? It doesn't show me what's happening at the upper esophageal sphincter. So is there any sort of constriction that's preventing food from going down? And it also depends too on the patient tolerance. I've had a small number of patients where I get that scope in there and they just can't tolerate it. So we have to end the exam and we don't really get a chance to do a good evaluation. So it depends too just on the patient's tolerance for that. The next one is the modified barium swallow study. And again, it's a awake procedure. You don't need to fast beforehand, unless it is combined with a full barium swallow study where you may be asked to fast beforehand, but typically you don't need to. If you're going to do the modified barium swallow study, that's it. And the difference with this one is that you're going to be eating and drinking in front of an X-ray machine. That food that you're eating and drinking is mixed with barium. It's a contrast, so that shows up on the X-ray. And I have a little YouTube link that kind of shows you what we're looking at. Hopefully there's no ads that pop up with it. It's so annoying that they've started doing that. So again, there we have the X-rays. And what I'm looking at is the jaw, the throat. I see that little piece of tissue coming up. That's the epiglottis. I'm looking at the hyoid bone there. She just swallowed, and I see things lift up and relax. So there we go. There's the barium, and she just quickly swallowed it. And so that's pretty much what we look at when we swallow for the modified barium swallow study. The benefits of this is that it really visualizes all phases of the swallowing. I can see what's going on in the mouth, the throat, the upper esophageal sphincter. If I have a good radiologist, they can do an esophageal pan, and we can see what's going on down below too. But some of the drawbacks is it doesn't, again, with the FEES, you can see the tissue health. This one doesn't show what's going on with the tissue inside of the throat, laryngeal biomechanics, are the vocal folds opening and closing, are there any deficits in that? And also, you get exposure to radiation. If that's a concern to you, that's something with the the barium swallow study, I really try to minimize the amount of exposure to that radiation that my patient is getting. So sometimes it has to be kind of quick and go through it really quickly. All right, so what's the big thing I'm looking for? Aspiration. What does that mean? It means entry of secretions or foreign material into the trachea or lungs. We all aspirate on things. It can happen when food goes down the wrong pipe. It can happen with our own secretions. But again, it becomes problematic when it becomes chronic or in larger volumes. This is really what we're looking for. This is what we're concerned about, is what's the lung health like. That's why things like pulmonary health, your respiratory status, that's important for me to look at when I'm doing your evaluation as well. Other things I'm looking for would be penetration. That's when food kind of knocks on the door of that aspiration, but doesn't quite make it down below the vocal folds. But it does get into that laryngeal vestibule, so it really kind of threatens to aspirate, but doesn't quite do it. I'm also looking at timing of things. How long does it take for that food to move from the throat, from the mouth down the throat and down into the esophagus? There could be timing issues with that. Say that food, you push it back beautifully to the back of the throat, but that throat doesn't quite respond the way that we would want it to. That throat doesn't work to constrict as fast. Well, if that food is sitting there for a longer time, that can also increase that risk that things might go down the wrong way, because food and liquid is going to go to the path of least resistance. A lot of times when it's not moving where it needs to go, it's going to go down to the airway. So I'm looking at timing of things. I'm also looking at how food is cleared. When you swallow, are you swallowing in like small bits from the mouth? Are you leaving food left over in the mouth? Is there any food left over after the swallowing? That's residue. Where's food sticking around? What does that look like? And also, how effortful? Does it take a lot of work for you to swallow a small piece of food? Those are things that I'm going to be taking into consideration as I look at your swallowing. All right, so what's next? We've had the evaluation, we've taken the history and everything. Is treatment indicated? What does the swallowing look like? What are the deficits? So usually, yes, treatment could be indicated. So what's important to do? Follow up with your SLP. Hopefully if they say, yes, I want to see you for treatment, then they set you up with some follow-up so they can work on exercises or strategies or whatnot. Just make sure that we're going along the same path. But a lot of times I see some patients and they don't follow up. So I really want to emphasize is that, yes, you do all of this evaluation, you do all of this history and everything. It's also important to see that speech therapist again, just to make sure that you're going on the right path. So swallowing therapy. Mainly three things that we look at for therapy are going to be diet recommendations. We're going to be looking at compensatory strategies. So what are some certain things that you can do to help you swallow a little easier? And then other exercises too, is exercise indicated as well. Really the overall goal for my patients is to put you on the least restrictive diet. Least restrictive meaning drinking thin liquids and regular solids, or what in that scale of viscosity is safe for you. So diet recommendations, we have the IDDSI, and I'm blanking on the acronym, the International Dysphagia Diet Standardization Initiative. We just actually started implementing this in the last year or so, but it gives you a visual of that scale of diet consistencies that we can look at. So from top to bottom, from bottom is thin liquid. That's your regular water, your coffee, your broths and soup. That's going to be the least restrictive. And from there, as far as liquids go, we can bring it up to maybe a slightly thick, or a nectar thick is what they used to call it. Mildly thick, that's more like a honey kind of consistency. If you have some fresh honey, drop it off a spoon. But again, that starts to sound less and less appealing as you go up. And as far as liquids go, who really wants to put some sort of thickener in their liquids every time they want to have a drink of something? That's just, so that's my goal, is to put you on the least restrictive. On the other end of that scale is we have regular foods, we have regular consistencies, things are, and then one below that is things that are easy to chew. So maybe not the well-done steak, although who wants to have well-done steak? I prefer mine medium rare. But steaks, breads, hard breads, those are going to be really probably the most difficult to chew and to swallow. So we're along that scale towards puree, so puree being like applesauce or yogurts or cottage cheese. What along that scale of food is easiest for you to swallow, and what kind of strategies can we implement with that? There are a number of compensatory strategies that can be prescribed. And I list a couple of these here. However, I do want to emphasize that this is all individualized on the patient that I see. Doesn't necessarily mean that a chin tuck is going to solve all of your swallowing problems. It might make it worse, but you want to have that looked at in your evaluation. So some positioning changes that can be done is, again, that chin tuck. When you swallow your chin down, if you turn your head to one side or the other, does that also help make it easier to swallow? This seating position too, you want to make sure you're seated upright when you swallow. It helps help gravity move things through your throat. There are some different swallow strategies that you can do. There's a supraglottic swallow where you hold your breath as you swallow and then you cough afterwards. So it looks like this. I'm going to take a deep breath. So I've held my breath as I swallowed, and then I coughed to remove anything from my larynx. Double swallow, sometimes just swallowing twice can help remove just leftover food in the back there. An effortful swallow, say it just takes a little extra work to do that. Small bites or sips, changing the size of the bolus that you're eating, that can be also helpful. If you're anything like my husband, he takes big bites and he's done with his meal in about 5 minutes. Whereas I'm a little more dainty with that, so with smaller bites and maybe taking a little more time with meals makes swallowing a little easier for you as well. Also, liquid wash too. That can, if you have food left over in there, and you just washing the rest of that down can help clear that leftover residue. Also, tools as well. You can have sometimes a straw is easier for you to drink your liquids, or sometimes the no straw is safer. A lot of times, some folks can't handle that liquid being pulled up from the straw and being shot right to the back of their throat. It just creates some coordination issues. So sometimes we recommend don't use any straws. But again, that's individualized to the patient. There are also certain tools out there. There are cups that give a predetermined volume. So when you swallow or when you go to take a sip from that, it gives you like 5 milliliters at a time, and it doesn't give you any more. You got to tip the cup over again, and then you got to try again. Exercises as well, and again, it depends on the deficits here. One size does not fit all. So there are certain exercises that I can use to help strengthen some of those muscles in the back of the throat. Effortful swallow, Masako, Mendelssohn. Those are good ones to help strengthen the muscles in the throat. But again, there's some issues out there if exercise is contraindicated. I might not want to prescribe those as well. Maybe doing things like maybe more I lean on compensatory strategies and maybe some diet modifications to make your swallowing safer. But overall, the best exercise for swallowing is swallowing. A lot of times with these exercises, you are swallowing through. And there are also tools out there that you can either purchase through insurance or on your own, and also other therapy programs that you can get involved with. So I just listed a couple of those. Sorry, I know I'm running out of time. I apologize. I just do want to give one word of caution is that Dr. Google is a very it's a very scary doctor. But if you're Googling through and you find, this swallowing tool, this swallowing exercise band thing or something like that, that's going to help with my swallowing, I would take that to your speech therapist. You want to use any sort of tool that says this is going to help your swallowing. Take that to your therapist so that you know you're using it the right way and that you know how to use it. I highly recommend that. All right, so all of a sudden done, you're looking at this, I think I have some trouble swallowing. I think I should see a speech therapist. We have an organization out there. It's the National Organization of the American Speech, Language, and Hearing Association. They have a wonderful portal there. It's asha.org. They have a lot of information, a lot more information on dysphagia, and also for speech issues too, speech language cognition. They have a lot of information for you, the public, that you can go to as a good reference. But if you're looking for someone, a speech therapist, they have their profile. So I have the URL up there. You can go in there, you can look up, these are the deficits that I'm looking for. These are, this is where I live. This is my age group. Find me someone. And we'll help you find that, or someone through the ASHA organization. So I encourage you first to talk with your doctor. Just like our PTs and OTs who spoke earlier, they said talk to your doctor, advocate for yourself. Talk to your doctor, say, I'm having trouble swallowing. I need to see a speech therapist. They usually need a referral first in order to see someone like me, but it takes you going to your doctor first and advocating for yourself. So talk with your doctor, come and find one of us. All right, thank you so much.